Thank you. Um, so this is going to be kind of head and neck at a glance. So for those of you who are more junior, it'll be a good sort of overview, right, of what the content areas and the main lesions are. And for those of you who are sort of more senior and boards prep, it'll be a good prep. If you were ever at the um, CPS one, it's pretty much very similar to that. But if you have um, questions or comments or anything, just please put them in the chat and I'll have that up on the side. And yeah, thank you for coming on Zoom only. I couldn't make it in this morning, so but I'll see you guys probably later in the day today. So okay, let's get started. All right, so all of head and neck pathology in an hour. We're going to do it. So we're going to start with squamous lesions because that's probably one of the most common. And so any clinician, physician, dentist, right, evaluating the mouth, the way that lesions start is usually as some kind of white or red patch, i.e. leukoplakia or erythroplakia. These are not histologic diagnoses. These are clinical appearances of which many pathologic diagnoses can be underlying, therefore biopsy is required. And so some of the more common non-neoplastic diseases that we see are at the bottom. The three on the right are those that often are aided in the diagnosis by immunofluorescence because they are some autoimmune, some immunologic phenomena. And those are lichen planus, pemphigus vulgaris, and bullous pemphigoid. Depending on where the antigen is, your deposition is either at the basement membrane, so you get sort of fibrinogen at the basement membrane in lichen planus. You get IgG-C3 at the basement membrane in bullous pemphigoid, and you get IgG-C3 in the desmosomes and pemphigus vulgaris. And so basically, lichen planus on H&E isn't necessarily blistering, but it's inflammatory. So it's band-like inflammation with very pointy, reedy ridges, and this sort of white streaks on red patches appearance clinically. Pemphigus vulgaris, because the antigen is within the epithelium, you get these intraepithelial blisters where you get retention of the basal cells at the bottom. And bullous pemphigoid, you get the entire epithelium lifting off from the basement membrane. Oral hairy leukoplakia and oral candidiasis are more infectious rather than immunologic. So oral hairy leukoplakia is EBV, usually presenting as this white area on the lateral border that cannot be wiped off. So both oral candidiasis and hairy leukoplakia kind of clinically look similar, but histologically, oral hairy leukoplakia has these very white balloon cells that show up positive on EBER. And oral candidiasis has this very hyperplastic look with this bulbous reedy neutrophils and yeast in the surface. Underneath the surface, you sometimes get stromal lesions. Common stromal lesions include both of these that have histologically similar lesional cells that are granular. Granular cell tumor, mostly a sessile lesion in various mucosal sites, anywhere from the tongue, down through the esophagus, trachea, etc. You get these cells that are S100 SOX10 positive that have indistinct cell borders and overlying pseudoepitheliomatous or sort of pseudocarcinomatous hyperplasia. Congenital epulis is a very characteristic exophytic pedunculated lesion on the alveolar ridge of newborns that has these granular cells that have very distinct cell borders that are not related to Schwannian differentiation, so they are S100 negative. They do not have pseudoepitheliomatous hyperplasia. Both lesions are benign and are basically cured by excision usually. Of course, the concern with all of these lesions, right, is could any of them be squamous dysplasias or keratinizing squamous cell carcinomas related, of course, to tobacco, alcohol, betel nut chewing in particular areas of the world. In order to grade, we sort of have a mild, moderate, severe, layout similar to other areas of the body. Some countries, Europe uses a low grade, high grade, but essentially we grade based on the level of atypical cells, as well as the severity of the atypia. And so you can, in the oral cavity, you can sort of upgrade dysplasia for the if the architecture or cytology is more complicated than the anatomic level in which it lies. So there's a lot of interim server variability, and there is a lot of squamous cell carcinomas that arise out of mild dysplasia that you do not need to progress from moderate to severe to in situ, right? So unlike the cervix, you usually go through this stepwise progression. In the oral cavity, you do not. And there is this overall field effect where people pop up with lesions all over their mouth, right? Because it's washed in these carcinogens. Tobacco, alcohol is just everywhere, right? So it can be very hard to treat these patients. In the end, many of them end up with invasive keratinizing SCC, in which depth of invasion, not tumor thickness, right, is critical for stage and for prediction of lymph node mets. So 3 millimeters depth of invasion predicts lymph node metastases in the tongue. 5 to 10 millimeters depth of invasion is critical for staging in the oral cavity, and and thickness, of course, is measured from the nearest adjacent basement membrane to the deepest tumor island, not from the top of the exophytic and not from the bottom of the ulcer, right? So you always have the same sort of calibration. The non-keratinizing SCCs are generally those of the Waldeier's ring, meaning the oropharynx and the nasopharynx, that are rich in inflammatory cells. The oropharynx being the palatine tonsils and the nasopharynx basically being the adenoids, right? Oh, I should also mention in the oropharynx, the lingual tonsil, right? The base of tongue. So the floor, the walls, and the roof. In the floor and the walls, right? The lingual tonsil and the palatine tonsils, we get HPV-associated oropharyngeal carcinomas that are usually related to high-risk HPV, often type 16, but it could be any of the other high-risk types. Nasopharynx, meaning the ceiling, in the adenoids, you get mostly EBV-associated nasopharyngeal carcinomas. All of these are squamous cell carcinomas that in which the virus usually enters the deep tonsillar, the deep adenoid crypts, and you don't often get surface dysplasia. You get this very blue on blue, often syncytial appearance with background inflammatory stroma. Of course, HPV E6, E7, mRNA-ish, and various other DNA-based methods can detect the virus. Good prognosis for HPV. We use EBER RNA to detect in the nasopharynx, in which case these are somewhat more radius sensitive than EBV negative nasopharyngeal carcinomas. We do not think about in situ carcinomas in these sites because they originate very deeply in the crypts where the basement membrane is discontinuous and the lymphatics are present in very close association with the neoplastic epithelium. Therefore, you can have a very tiny lesion, a very deep lesion that is already metastatic. So there is no such thing as virus-associated dysplasia. These are usually just broad-based invasions. We all know that P16 is a surrogate marker for HPV, in which case you must need over 70% nuclear and cytoplasmic staining in your tumor cells in the oropharynx in order to be predictive of HPV. There's a low positive predictive value for HPV in other sites, so it is really not used in other anatomic sites. So we use P16 in which settings? All new oropharyngeal cancers and lymph node metastases of unknown primary. Now the College of American Pathologists has updated their guidelines from 2018 to now, like 2 months ago, actually also encouraging us to do high-risk HPV testing on sinonasal squamous cell carcinomas because these also have a not insignificant frequency of high-risk HPV, and prognosis is also better in these patients. For FNA, P16 can often be false negative, so we actually prefer HPV messenger RNA because this is both more sensitive and more specific. We do not provide tumor grade or differentiation status for viral cancers because even though these are very blue, very basaloid, very quote unquote poorly differentiated, they do not behave as such. If you see malignant epithelium in a neck cyst or a neck lymph node, this is not carcinoma arising in a branchial cleft cyst. This is metastatic squame, likely HPV, do your HPV testing. Okay, so we're gonna move deeper into the meaning no nuclei in the lacunae, acute inflammation of neutrophils and oral flora, generally actinomyces and various cocci. This can either be one of three things: medication, usually bisphosphonate-related osteonecrosis, osteoradionecrosis secondary to radiation for other malignancies, or true like traumatic infectious osteomyelitis of jaw. And one needs to know the clinical context in order to differentiate between these three, but they all look histologically the same. One of the more common neoplastic lesions of jaws are these odontogenic cysts that arise around the crowns of unerupted teeth. And those of you who have sat on Mark Langen's service have probably seen these. So we have to look at the epithelium for identification. We're generally dealing with an odontogenic keratocyst, a dentigerous cyst, or an ameloblastoma. Dentigerous cysts kind of being probably the most common, just as generic bland squamous lining, often inflammatory. Curettage is curative. Sometimes you get more columnar gland-like cells. That's fine. However, if you see any lining at all that looks OKC-like, meaning 5 to 7 cell layers thick, with a palisaded or regular basal layer, with this surface undulating corrugated kind of cardboard keratin, and daughter cysts in the wall, this is OKC. These patients need marsupialization, meaning kind of exposure, like a kangaroo, like exposes the inside of the sac, or caustic therapy of the cyst lining, because these are very prone to recurrence. Multiple bilateral mandibular and maxillary OKCs, think Gorlin syndrome. These patients also get other diseases like basal cell carcinomas, medulloblastomas. Ameloblastoma can be cystic or solid. The solid ones are generally more easy to diagnose with reverse polarity, central stellate reticulum. Reverse polarity, meaning the nuclei are not oriented at the basement membrane. They're kind of oriented away from the basement membrane. So there's like a little bit of a lifting off of the nuclei. The cystic ameloblastomas can be hard to diagnose because the epithelium can be very nondescript. However, BRAF V6G positivity can help in the diagnosis, as very many of these are BRAF positive. Treatment for ameloblastoma is generally hemimandibulectomy. It's thought that in some cases where conservative therapy is desired, you can enucleate a unicystic ameloblastoma, but you certainly should not enucleate any of the others because they will recur and recur and be locally destructive. Ameloblastic fibroma is clinical pathologically generally posterior mandible of kids. You have very compressed ameloblastic islands with very bland stroma. These are actually at risk of malignant transformation of the stromal compartment to ameloblastic fibrosarcoma, which looks like a high-grade spindle cell sarcoma with the background of these ameloblastic nests. I should mention you can get ameloblastic carcinoma, which looks more like an ameloblastoma, but overtly malignant. Lots of mitoses, necrosis, pleomorphism, whereas ameloblastoma, really no mitoses, no necrosis, no significant pleomorphism. All right. Bony lesions of odontogenic origin include cemento-ossifying fibroma, which is related to CDC73 mutation. Potentially, if it's in the germline, you might be dealing with the hyperparathyroidism jaw tumor syndrome, in which these patients also have, guess what, hyperparathyroidism. Generally, the stroma tends to be variably cellular. The spicules of bone are variably sized and shaped. You get these little purple cementum-like particles. These are sharply demarcated and expansile. In contrast to fibrous dysplasia, is very poorly demarcated, characteristic buzzword ground glass appearance, very monotonous stroma, paucicellular with monotonous curvilinear strands of bone with Sharpay fibers kind of ossifying out of the fibrous tissue. Fibrous dysplasia does not have osteoblast rimming because it sort of ossifies right out of the stroma. Ossifying fibroma does have osteoblast rimming. Fibrous dysplasia related to GNAS mutations, especially in germline polyostotic syndromes. Osteosarcomas of the gnathic bones, i.e. the chewing bones, right, the jaw bones, mandible over maxilla, generally is in a mean age of sort of 30s. Mostly it's morphologically chondroblastic, meaning it produces a lot of cartilaginous matrix. but you must see somewhere some kind of osteoid matrix in order to call it osteosarc, but mostly you're going to see cartilage. These undergo resection as primary therapy because chemotherapy is not really as effective compared to the osteosarcs of the long bones that we'll see in the board's review for BST in a couple of weeks. Questions so far? Okay, moving up into the sinuses. So these three, even though we in this country don't really see rhinoscleroma or rhinosporidiosis very often because our native population is not infected with these diseases, you can see it in people from outside the US or who've undergone travel. So rhinoscleroma is bacteria that's present in these foamy macrophages that you can see on Warth and Starry stain. Rhinosporidiosum is a fungus that creates these sporangia in the stroma and in the epithelium. Myospherulosis mimics an organism, but it is actually not. It is red blood cells that are coated in basically Vaseline, like petroleum, that they pack the sinuses with. So if you do a GMS on here, it will be negative. But you can see myospherulosis in any anatomic site that has undergone some kind of surgical packing. Wegener's, now known as granulomatosis with polyangiitis associated with C. ANCA, so always correlate with serologic studies. You generally want to look for a triad of granulomas, vasculitis, and neutrophilic microabscesses, but neutrophilic microabscesses are probably the one that you're going to see most commonly. You may or may not see vasculitis and granulomas, so always, ask for correlation with serology. So there we have those findings on higher power. Sinonasal, formerly known as Schneiderian papillomas, are of the specialized quote-unquote Schneiderian membrane of the sinonasal cavity. The inverted and cylindrical cell, now known as oncocytic types, tend to occur on the lateral nasal walls. They are related to either mutations in EGFR or KRAS, respectively, with very few of them being related to low-risk HPV. They have both endophytic and sometimes exophytic growth. They all have neutrophilic microabscesses in the surface epithelium, and they all can progress to carcinoma in a small subset of cases. The exophytic type on the septum is generally related to low-risk HPV, definitely more exophytic, but unlike the characteristic squamous papillomas of the tongue, for example, the epithelium is extraordinarily thick and can kind of spread along the septum in a horizontal fashion as well. It's a little bit easier to excise, and so carcinomatous transformation in these is somewhat rarer. Sinonasal adenocarcinomas can be of multiple types. The most common kind of clinical pathologic correlate is the intestinal type that looks like colon cancer. It stains like colon cancer, and it is related to patients who have received occupational exposures to things like wood and leather dust or other carcinogens. So if they have occupational exposure, they do not have any colon cancer, then you can sort of say, yes, this is primary intestinal type sinonasal. Non-intestinal type is more nondescript, kind of these back-to-back cribriform glands with CK7 expression only. There is a subtype of non-intestinal type sinonasal adenocarcinoma that's actually renal cell carcinoma-like adenocarcinoma. It looks like clear cell RCC, but is Pax8 negative, which is a good discriminator from a potential metastatic RCC to the sinuses. Nasopharyngeal angiofibroma is a mesenchymal tumor of the sinuses that occurs in usually adolescent males, sometimes associated with familial adenomatous polyposis. Slit-like blood vessels, very richly vascular, lots of nosebleeds in these patients. With this background fibrous stroma, the cells of the background stroma are positive for androgen receptor and beta-catenin, so you can pick them out in that way. These are often embolized prior to surgery, so you might see embolic beads in the lumen of the vessels. Sinonasal spindle cell tumors, the three most common ones are solitary fibrous tumor, which is just like SFT and other anatomic sites. It's positive for CD34 and STAT6. It has these dilated hemangioparasitoma, quote unquote, like vessels with collagenous stroma. Glomeangioparasitoma is usually somewhat more cellular, has a more glomoid or monotonous appearance to the cells. Because these are perivascular myeloid neoplasms, i.e. glomoid, they do stain for smooth muscle actin. They're also related to beta-catenin mutations. They tend to have hyalinized blood vessels. Biphenotypic sinonasal sarcoma, meaning with neural S100 and myogenic SMA differentiation. They have PAX3 mammal3 fusions and can sometimes kind of aberrantly express PAX8 in the stromal neoplastic cells. They often have this downward sort of proliferative respiratory epithelium that is thought to be non-neoplastic, but just kind of induced by the tumor. We do not use the term hemangioparasitoma anymore in any anatomic site, although you may hear the vessels of an SFT being referred to as HPC-like, because that's what this tumor used to be called. Then we get into the high-grade, very, very, very cellular, very blue cell tumors of the sinuses, of which case you will 100% need immunostains to distinguish them. There are the carcinomas. They're very strongly keratin expressing, and then some of the non-carcinomas. The exception is Ewing sarcoma of the sinuses in this so-called adamantinoma-like Ewings can actually very strongly express keratin. So I would always sort of consider that in the sinuses. Do your CD99 and your Fly1, your ERG, to see if you can go down the Ewing sarcoma pathway. Olfactory neuroblastoma as well can sometimes express keratins. Usually you have a more bland cytology with sort of neuropel and rosettes. There's also this newish entity of olfactory carcinoma that is generally very high grade and very strongly keratin expressing. So kind of a spectrum here. Then we get into neuroendocrine, full-on neuroendocrine carcinoma that is similar to neuroendocrine carcinomas in other locations. I don't know. I think there's probably a spectrum between olfactory neuroblastoma, olfactory carcinoma, and neuroendocrine carcinoma that we just haven't really sorted out yet clinically, but I just wanted to point out this spectrum. Of course, the non-keratin expressing malignancy is going to be melanoma, which is going to be probably easier to pick out with, your melanocytic markers. And then the other carcinomas at the top that are non-neuroendocrine expressing. We're dealing with anything from nasopharyngeal carcinoma, which we know to be EBV related, and squamous differentiation, to this DEC-AF sinonasal carcinoma that can mimic a sinonasal papilloma because of its growth pattern. It's related to DEC-AF gene fusion. There's this HPV related or adenoid cystic-like sinonasal carcinoma that also shows squamous differentiation, but expression of P16 and positivity for high-risk HPV, specifically HPV 33. You have your SNF deficient carcinomas that are SMARCB1 or SMARCA4, INI1 or BRG1 loss. These often have rhabdoid, right, differentiation, right? So we know that many tumors with rhabdoid differentiation can either be true rhabdomyoblastic or chromatin complex remodeling deficient. Then there's nut carcinoma that tends to have abrupt keratinization, but not always. This has positivity for the nut nuclear stain and translocation of nut gene. And then we are left with SNUCs or sinonasal undifferentiated carcinomas, which is essentially a diagnosis of exclusion. Now many SNUCs have actually been shown to have recurring IDH2 gene mutations. So this is probably a disease entity in and of itself. The sinonasal tumors, as you can see, are burgeoning, in the last 5 to 10 years. A lot of these have kind of come to knowledge. So keep your eye out for what other ones are going to be diagnosed based on genetics or morphology in the future. And now moving ourselves on down to the larynx. The larynx is divided into 3 anatomic compartments: the supraglottis from the tip of the epiglottis to the ventricle, meaning the space between the false and the true chord; the glottis, meaning the true chord to about 1 centimeter below; and the infraglottis, 1 centimeter below to the inferior border of the cricoid cartilage. This is one of our nice cut sections of larynx where we go from the mucosal side all the way through to the thyroid cartilage, out to the strap muscles in front. I'm showing this here because invasion of tumor in squamous cell carcinomas is related to which anatomic compartment these tumors invade into, as we will talk about shortly. First, we'll start with the benign lesions. Very commonly, we see vocal cord polyps. These are related to vocal trauma, singers, teachers, etc. They can be unilateral, bilateral. They all present with a range of histology anywhere from ectatic stromal vessels, myxoid stroma, hemorrhage, thickened basement membranes, this eosinophilic amyloid-like material, which is not, in fact, amyloid. These atypical stromal cells, we call them vocal cord polyps, and move on. You can also get true cysts of the vocal cords, in which case you would see an actual epithelial lining in a cyst. Squamous papillomas, low-risk HPV related, generally type 6 and 11. They can be single, they can be multiple. If they are multiple, these patients often acquire them when traveling through the birth canal of the mother. They pop up multiply and recurrently throughout life, throughout the deep tracheobronchial tree. Occasionally, they can lead to squamous cell carcinomas, especially if there are additional environmental exposures. You may or may not actually see coilocytes, right? Coilocytes being wrinkled, racinoid, dark nuclei, binucleated cells, perinuclear halos. SCC is most common in the larynx and the glottis. In other countries, more common in supraglottic sites, but of course you can get origination in any anatomic site. These are related, just like our conventional oral cancers, to our environmental carcinogens. Transglottic means that the tumor travels from one site of the larynx to another, meaning it spans the glottis and the supraglottis, or the glottis and the infraglottis. So that defines transglottic. However, prognosis is also related to not only how many sites does it span, but how far out of the larynx does it go? Does it invade the cartilage? Does it invade the strap muscles? Histologic grade is limited, and so as you know, we here do not grade any of our squamous cell carcinomas in any anatomic site of the head and neck. We provide a keratinization status and a tumor stage, and if necessary, viral association. Okay, neuroendocrine tumors of the larynx are kind of following the low grade, intermediate grade, high grade, just like other anatomic sites. The sort of carcinoid, atypical carcinoid, neuroendocrine carcinoma breakdown related to mitosis, necrosis, pleomorphism. Most common in the larynx is the intermediate grade. You're all very familiar with the immunoprofile of neuroendocrine tumors. In the larynx, I would just be careful. Sometimes they can express calcitonin, and you may think, oh, could this be a medullary carcinoma invading backwards from the thyroid gland? So just, check the thyroid if there's ever a concern for that. Laryngeal sarcomas, we're mostly dealing with chondrosarc. I've never made a diagnosis of a laryngeal chondroma, so chances are you're dealing with the chondrosarc. They're generally greater than 2 centimeters. They generally have some amount of cellular atypia and increase in cellularity. So on the right, you see grade 1, grade 2. These are graded just like chondrosarcomas of the long bones, grade 1, grade 2, grade 3, and then D. diff. Just like osteosarcs of the jaws, these are treated primarily by local excision with clean margins, because response to chemo is not really a thing. Okay, moving into lesions of the ear. Most common tumor of middle ear is jugulotympanic paraganglioma. You may hear these referred to clinically as glomus. Glomus tympanicum if they're in the ear, glomus jugulare if they're in the neck. This is not a glomus tumor of the perivascular myoid neoplasm type. This is a little bit of a misnomer, but in the head and neck clinical world, you may hear this referred to as that. Know that these are paragangliomas. They express neuroendocrine markers. They are keratin negative. They have F100 positive subtentacular cells surrounding the nests or the Zellballen. For all paragangliomas of the head and neck, we should be screening these patients for possible succinate dehydrogenase germline mutation. So if you get a paraganglioma of the head and neck, do the SDH stain. We have it here. We should be doing it on all paragangliomas. The reason is because germline mutation is the most predictive of behavior. For SDHB, germline mutations having aggressive behavior. Most common, however, is SDHD. If you see absence or extraordinarily weak expression of SDH compared to your stroma in these tumors, these patients should be screened for germline mutations, because otherwise there is no good morphologic criteria or good histologic scoring system for prediction of metastatic potential in these. There is a brand spanking new protocol for the examination of paragangliomas and PHEOs that just came out in the College of American Pathologists. So check for this if you have either an adrenal, PHEO or an extra-adrenal paraganglioma. You can use this staging system should you desire. All right, other middle ear tumors include those with keratin expression. This would be middle ear neuroendocrine tumor, formerly known as middle ear adenoma. These generally express keratins and neuroendocrine markers. They have this ribbon-like morphology. Ceruminous adenomas really usually recapitulate the kind of apocrine-like morphology of the ceruminous glands with this bilayered epithelium, almost kind of like a pleomorphic adenoma. Papillary endolymphatic sac tumor, you mostly are going to see on your neuropath surface. This is coming from in your inner ear, your deep temporal bone, associated with von Hippel-Lindau, papillary morphology, clear neoplastic cells, clear cytoplasm, locally invasive but non-metastatic. All right, salivary gland. Wow, we're really not rushing, but we're making good timing on this. All right, salivary gland tumors. Salivary carcinomas are a small percentage of all head and neck cancers, usually in a clinical note, right? When you see the word head and neck cancer, generally that means head and neck squamous cell carcinoma of a mucosal site. However, we know that there are other cancers, and so we like to be much more specific. When we're dealing with salivary tumors, mostly we're dealing with the parotid. However, as you know, you can get salivary gland malignancies in any site that has any kind of major or minor salivary gland, right? The major glands being parotid, sublingual, submandibular. The minor glands being anywhere in the upper aerodigestive tract, all the way down to your trachea and your bronchi. In most common malignant site is going to be sublingual. Epidemiologically, most common tumor is PA, followed by Warthin. For benign, most common malignant is mucoep, followed by adenoid cystic. Remember, mucoep is one of these neoplasms that can also occur in kids, one of the rare carcinomas that can occur in children, in addition to thyroid carcinomas. I'm going to start with some benign diseases of salivary tissue that we see before getting into the tumor. So necrotizing sialometaplasia, we often see as a squamous metaplasia of salivary acini and salivary ducts, likely due to some kind of ischemic change following surgery, following radiation. In patients who have histories of squamous cell carcinoma, this can sometimes be difficult to differentiate from SCC, especially if it's on a small biopsy or on a frozen. But you want to see maintenance of the ductal lobular architecture. You want to see that the nests have very rounded borders instead of the pointed borders of invasive SCC. You can often see neutrophilic debris in the residual lumens of these ducts. You can sometimes see mucinous cells, giving you an indication that these are, in fact, salivary units. Benign tumors and malignant tumors of salivary glands. So I tend to conceptualize these as which tumors can be benign with a malignant counterpart, which are essentially only benign, and which are only malignant. And so this chart is either the only benign or benign with malignant counterpart. Pleomorphic adenoma has two cell types, epithelial and myoepithelial, related to PLAG1 and HMGH2 genes. Basal cell adenoma and adenocarcinoma, also two cell types, CYLD or beta-catenin gene. Myoepithelioma probably doesn't exist. These are probably just duct pore pleomorphic adenomas. But we do believe in a myoepithelial carcinoma, some of which have EWSR rearrangements. Oncocytoma does exist. Oops. But there's a controversy about whether oncocytic carcinoma truly exists. It's probably just an oncocytic variant of some other salivary neoplasm like mucoep. Warthin tumor and canalicular adenoma certainly are out there. Let's start with PA. So we know that it is a biphasic epithelial and myoepithelial neoplasm with chondroid stroma. What it can do is it can recur, especially after incomplete excision, and it recurs as these sort of multiple small nodules within stroma. that can be very, very hard to excise. You can see these teeny weeny little nests here at the bottom to these larger ones that are very stroma rich. Sometimes the stroma shows tyrosine crystals. It's just a little interesting fact. We don't really see these tyrosine crystals in any other neoplasm. It can also transform right to a malignant carcinoma X, PA, in which case it would generally retain the genetic driver. It usually starts as some kind of in situ or intracapsular proliferation within the duct of the PA that does not breach the border. If this is the case, these have very good behavior. However, if it infiltrates beyond the border of the PA, this is high grade and aggressive. Generally, it can be of any morphologic type, but salivary duct is one of the more common morphologies of carcinoma X. There's this controversial benign metastasizing PA, to be determined if this is actually a thing, but there are some reports of what looks like a pleomorphic adenoma metastasizing without having malignant morphologic transformation, but this may not be true. Now that we know a little bit more about tumors, it may probably just be a, who knows, a myoepithelial carcinoma or something. Okay, Warthin tumor, commonly seen in smokers, commonly bilateral, has never been demonstrated to actually be neoplastic, so this might just be a reactive proliferation of oncocytes with cystic change in a background of like lymphoid tissue that almost looks like a lymph node. You get this bilayered oncocytic epithelium. These can pop up on PET scans, like people have cancer, they get a PET scan, something pops up in their salivary, it's often a Warthin. Pitfall is Warthin like mucoep, in which case mammal-2 gene rearrangement would be provative of mucoep. Oops, wrong way. Basal cell adenoma, adenocarcinoma. The adenomas can have mutations of beta-catenin or CYLD, the cylindroma gene. The adenocarcinoma is generally just the CYLD gene. This is the same gene mutated in these familial sort of, I know they used to call them turban tumors. It's basically familial dermal cylindromas. Both adenomas and adenocarcinomas have this nested growth with peripheral palisading, the eosinophilic basement membrane material. Basal cell adenomas can also have this cellular stroma in the background that is diffusely strongly positive for S100. Here you see beta-catenin focally present in the nuclei. It's not always in every single nucleus, but if it's present in any nuclei, it's generally regarded as positive. The difference between adenoma and adenocarcinoma is, of course, the presence of invasion. Usually they're low grade. Myoepithelial carcinoma can either transform from a PA or be present de novo. It generally has this large nested growth pattern with accentuation of cellularity at the periphery and hypocellularity in the center. Cords of myoepithelial cells present in mucinous stroma. For immunoprofile, you need to see a few things. You need to see a presence of an epithelial marker that's keratin or EMA. And you need to see presence of usually multiple from the following buckets. Some kind of myeloid marker like SMA calponin, often, but not always, some kind of basal marker like P63, P40, and usually some kind of neural crest marker like S100, SOX10. So we apply a panel approach when diagnosing myoepithelial neoplasms because they can be highly variable in terms of which one of these they express. They can be morphologically very bland and still be aggressive and metastatic. So this is one of the ones we as head and neck pathologists are always very kind of afraid of. The tumors that are, the one thing I didn't mention, I'm going to just go back. Canalicular adenoma, I do want to mention, is very specific in terms of it's often on the upper lip of elderly females. It has this monophasic morphology of these sort of rows of neoplastic cells with a loose vascular stroma. But if you see a tumor on the upper lip of an old, lady, think about a canalicular adenoma. Okay, malignancies. So again, how many cell types are present and what are the genetics? Mucoep has mucinous, squamoid, and intermediate cells, CRTC1 mammal-2 gene rearrangements, CRTC3 being next most common, adenoid cystic MIB or MIB-L1 NFIB, epithelial myoepithelial carcinoma HRAS, acidic cell NR4A3 fusions, secretory ETV6 NTRK, polymorphous cribiform. These are parts of the same family, either PRKD1 mutations or fusions. EWSR ATF1 fusion in clear cell carcinoma, most commonly RET fusions in so-called intraductal carcinoma, and salivary duct with a heterogeneous genetic profile, but usually androgen receptor and HER2 expression. So let's go through them. Mucoep, your mucinous cells on the left, your intermediate cells in the center. These are very kind of bland, nondescript, but these are often the most common cells you're going to see in mucoep. And then occasionally you'll see squamoid cells on the right. They can be solid or cystic. You should grade them according to the, usually we use the Brandwein grading system, in which case a low or intermediate Brandwein grade is generally biologically indolent, but a high Brandwein grade is probably biologically high grade. Adenoid cystic carcinoma, also 2 cell types and 3 histologic grades that are generally how much percentage of tubules, as you can see here in the middle, how much percentage of cribiform, as you can see on the left and right, and how much percentage of completely solid growth. Perineural invasion is very, very common in these patients. Recurrence and metastases, sort of regardless of histologic grade, is also very common. So even though adenoid cystic generally, yes, can be assigned a grade, it is kind of considered already much more aggressive than any of the other salivary counterparts, no matter what grade it is. It can undergo frank dedifferentiation, which we'll see momentarily. You can point out the 2 cell types with your immunostains. Usually I use c-KIT or CD117 for the epithelial cells and P40 for the myoepithelial cells. It's the myoepithelial cells that secrete basement membrane material or connective tissue mucin. And it's this connective tissue or bluish mucin that fills the spaces of the adenoid cystic and present on cytology, right, as those sort of like bubblegum-like materials. A Sinonasal carcinoma is exactly as it suggests, sheets of serous acinar cells that stain positively for PAS and are resistant, to diastase. These are the zymogen granules, right, or the predigestive enzymes of the salivary units. They also stain for DOC1 in the apical surface or membranes, and NR4A3 picks up those that have the NR4A3 fusions. Any salivary carcinoma can undergo high-grade transformation or dedifferentiation. Actinic and adenoid cystic are some of the more common ones to do so. On the right, you see, if you look at this, you would have no idea what to call it. It looks high-grade. It's got mites. It's got prominent nucleoli. So you either have to look for a defining gene fusion or some pre-existing lower grade areas. Polymorphous adenocarcinoma used to be called polymorphous low grade, but we now realize that not all of them are actually low grade. So we removed the low grade from the name and we now grade it mitoses, necrosis, pleomorphism, etc. The most common location of polymorphous is thought to be the palate, but the most common tumor in the palate is not polymorphous. You're still dealing with things like pleomorphic adenoma and adenoid cystic. However, on your differential diagnosis, polymorphous is of a single cell type, not biphasic. Every single cell here stains for S100. Every single cell here is negative for P40. So that can be a good breakdown for your differential diagnosis. It has this variety of growth pattern from this sort of whorling or lobulated or glomeruloid to sheet-like or solid to cribiform. It can have PNI, however. PRKD fusions and mutations, as we said, can be present in either the polymorphous or so-called cribiform subtype. The ones that are outside the palate have been referred to as the cribiform subtype, but honestly, I think this is more of a spectrum than was previously thought, and I'm not sure that polymorphous and cribiform are actually distinguishable, but if you read the WHO, that's what you'll read. You can see that if you want to make this diagnosis on H&E, you can almost get there in as much as you do not see myoepithelial cells around these tubules, so you can at least assume that this is a monophasic, not a biphasic tumor. And of your monophasic tumors, Your other differential diagnosis might be something like secretory, which stains also diffusely strongly positive for S100, but also for mammoglobin and has ETV6 untracked fusion. You can see in the lumen, you have this very kind of watery secretory material. Sometimes it's inspissated and thick. Sometimes it has a micropapillary pattern. So think secretory when you see this kind of microcystic pattern, S100 mammoglobin. Salivary duct carcinoma looks kind of like high-grade DCIS with apocrine morphology, but this is essentially all invasive. You usually will not see a P40, P63 positive basal layer around the edges of these nests, except if you have some kind of intraductal spread, but that should only be focal. You see androgen receptor strong nuclear and generally HER2 membranous. They ask for these in salivary tumors mostly for treatment purposes. So can they treat the patient with androgen antagonists? Can they treat them with Herceptin? Because these are good therapeutic targets. ER/PR should not be positive to any significant extent in a salivary tumor. If it is, it's a metastasis from a breast cancer. Epimyoep, as its name suggests, is also biphasic. You have epithelial cells that are sort of punctuating these larger nests and islands of myoepithelial cells, often which have very clear cytoplasm. The biphasic nature is readily apparent, usually on H&E, and you can highlight with immunostains if need be, HRAS mutation. All right. A sip of water before getting into, as you all know, my favorite organ, the thyroid gland. So here's our chart of our non-neoplastic most common entities, ranging from Hashimoto's, which we see very commonly, lymphoid follicles with germinal centers and oncocytic metaplasia of the thyroid follicles related to antithyroid peroxidase antibodies. Let's skip for a moment to Graves' disease, which is related to thyroid stimulating immunoglobulins. So you are either in a hypo, right, or a hyperthyroid state, but many patients can vacillate between these two. In Graves, you generally see papillary hyperplasia with these papillary infoldings into the lumen. Other thyroidities include granulomatous, which can happen after a viral upper respiratory infection, fibrosing or Riedel thyroiditis, which is really, really hard clinically. You get this IgG4-related sclerosis with plasma cell infiltration that often extends into the extrathyroidal tissues, like the skeletal muscle, and can actually mimic malignancy because of its sort of infiltrative growth process. But this is basically fibrosis. And then on the right, dysharmonogenic goiter, which is very rare, but it's related to genetic defects in thyroid hormone production or function. And you get these very cellular nodules within a very cellular background. Usually this is presents in children. Moving into the neoplasms. So we have this subset of neoplasms that are called not adenomas and not carcinomas, but either tumors or neoplasms. And this is the sort of low risk thyroid neoplasm category, in which these patients do not require any ancillary therapy, just clinical observation. The first one is hyalinizing trabecular tumor. This is very well circumscribed. It has tumor cells that grow in these nests and cords. The tumor cells are often oriented sort of perpendicular to the long axis of the trabeculum. They do have papillary-like nuclei with true intranuclear cytoplasmic pseudoinclusions, wrinkles, folds, grooves. They have recently been discovered to have GLIS-PAX gene fusions, so that can be diagnostic if you are ever in a pickle. Your diagnosis might be papillary thyroid carcinoma, but you don't see either papillae or follicles or invasion. Your diagnosis might be paraganglioma, but look for these nice, good nuclear features. When we move into the carcinomas, we will start with the well-differentiated follicular cell-derived thyroid carcinomas, of which the types are papillary, follicular, and oncocytic. Oncocytic, formerly known as Hürthle cell, but we now know that Hertel probably did not even describe oncocytes, so his name has been removed. Papillary infiltrative related to BRAF V600E mutations, RET PTC rearrangements, or NTRK or BRAF fusions, follicular thyroid carcinoma, RAS mutations, PAX8 PPAR gamma rearrangements, and other mutations, including the non-canonical BRAF, i.e. BRAF K601E, oncocytic related to mitochondrial DNA mutations, as well as copy number alterations. Papillary is, of course, going to invade your lymph nodes. It's going to spread to your level 6 and lateral neck nodes. However, prognosis is very good, even in the presence of lymph node mets. However, follicular and oncocytic, they tend to get into vessels. They travel to your bone, your lung, your brain, your liver. These are much poorer prognoses because this is now a systemic rather than a local regional disease. Subtypes of papillary include the tall cell, which is usually very pink and has BRAF V600E mutations, columnar cell, which is very blue and almost endometrioid looking and has these sub or supranuclear vacuoles, tends to be more aggressive only if it is widely invasive. Diffuse sclerosing is present as sort of bilateral involvement, often in teenage females, with lots and lots of psammoma bodies, occasionally with squamoid morules, but these are treated aggressively and do very well. Cribriform morular used to be a subtype of PTC, but it has now been removed because it has been shown to be PAX8 negative, so it is not even clear if this is of thyroid follicular cell differentiation. What we do know about it is that it has cribriform growth. It often has squamous morules. It generally has beta-catenin expression in the nucleus because it has beta-catenin mutations or APC mutations if it is associated with familial adenomatous polyposis. So always, investigate for potential germline syndrome in cribriform morular. Okay, criteria for NIFTP, meaning one of our other non-adenoma, non-carcinoma tumors, NIFTP being non-invasive follicular thyroid neoplasm with papillary-like nuclear features. NIFTP used to be called the non-invasive encapsulated follicular variant of papillary thyroid carcinoma, but now we know that these are not behaviorally like papillary carcinoma. To me, in a nutshell, these are basically follicular adenomas with nuclear atypia that can be scary. So basically they are encapsulated or circumscribed without invasion. They basically have little or zero true papillae, zero psammoma bodies, zero high-risk features, zero evidence of BRAF mutation or high-risk mutations. Of course, zero invasion, but some presence of atypical nuclei, meaning size and shape, membrane irregularities, chromatin clearing. Usually these will not have true pseudo-inclusions. The presence of true pseudo-inclusions may direct you to either a true PTC or even potentially an oncocytic lesion, because sometimes those can have pseudo-inclusions. Here is the sort of somewhat arbitrary cutoff point for when to call something a NIFTP and when to not. We can have a philosophical debate over this for hours, in which I would be happy to, just not right now. So NIFTP is a RAS mutated follicular neoplasm that is non-invasive and basically is biologically a follicular adenoma with some nuclear atypia. Okay, moving up in the world. So we talked about your follicular and your papillary and your oncocytic carcinomas, your NIFTP, which is not a carcinoma. So now we'll move into the high-grade follicular cell-derived, but not anaplastic carcinomas, meaning your poorly diff and your high-grade diff. These can transform from a PTC or an FTC or an OTC, but what they have is either increased mitoses or necrosis. So if you take anything away from this slide, take away the yellow. For poorly diff, they must be solid or trabecular or insular growth with invasion. They do not have papillary carcinoma nuclei, but they do have mitoses or necrosis. These often transform from follicular and are RAS-like. High-grade diff is this newer category that arose because poorly diff was not capturing all of the high-grade carcinomas. So what if it didn't have solid growth? What if it had papillary growth, but it had mitoses or necrosis? What if it was like a follicular carcinoma, but it had mitoses or necrosis? These were not captured. We now know that these behave worse, and we now have a method for capturing them. So we have our high-grade non-anaplastic, meaning either our papillary or our follicular or oncocytic, or our poorly diff high-grade that can transform, or they can just jump straight to anaplastic. Anaplastic being it no longer looks like thyroid, it looks spindled, it looks epithelioid, it even looks squamous. Survival is significantly different, significantly lower. With anaplastic, they try to treat these with BRAF inhibitors if they are in fact BRAF V600E mutated. So it is in the high grade and in the anaplastic that they really, really need molecular testing in order to potentially treat them with BRAF inhibitors or NTRK inhibitors if that's the case. Here's what poorly diff looks like, very solid, very cellular with mitoses and necrosis. Necrosis without other evidence of biopsy site, right? Biopsy site being hemorrhage, hemosiderin, fibrosis, histiocytes, whatever. High-grade papillary, in this case, you can see there are still these architectural structures with good, nuclear clearing and grooving and wrinkling. However, we do have central necrosis. So this is high-grade PTC. High-grade FTC, again, looks like an invasive follicular carcinoma, which still grows in follicles, but oops, has mitoses and necrosis. That's high-grade follicular. So always ask yourself when you make a diagnosis of carcinoma, can it be worse? Do I see mitoses? Do I see necrosis? Because you may buy the patient an upgrade in their diagnosis. And not to forget our friend medullary, that is not related to follicular cells at all, but to C cells. Familial is often multifocal, often earlier in age, sporadic, often older, often unifocal. However, we are now doing molecular testing of all MTCs. If they have a RET mutation, the patient then proceeds to germline testing. As you all know, these look like C cells with granular purple cytoplasm, salt and pepper chromatin. Sometimes you'll see amyloid deposits. Amyloid here is just the calcitonin protein that's folded into the beta-pleated sheets. These can metastasize both to lymph nodes and to distant visceral sites. And in the last 2 minutes, excellent, we are dealing with parathyroid. So the three kind of diagnoses I wanted to mention with parathyroid, because mostly, right, you get a patient with hyperparathyroidism, you get the para, it's enlarged by weight, it's hypercellular by histology. We call it an EHPG, an enlarged hypercellular parathyroid gland, and we move on. However, if we start seeing atypical features, those atypical features are dense fibrous bands, solid growth. What happens if you start to see necrosis, prominent nucleoli, coarse chromatin? The way to make a diagnosis of parathyroid carcinoma is only the presence of either metastasis or destructive invasion into the adjacent structures, such as thyroid gland, muscle, or things like vascular or perineural invasion. Otherwise, we're just dealing with kind of an atypical parathyroid neoplasm. If you do parafibroma immunostain and it is lost, that does not mean that it's malignant. It just means that these patients have risk for CDC73 germline mutation. Where did we see CDC73 earlier in this lecture? That's right, hyperparathyroidism jaw tumor syndrome, where you get ossifying fibromas of jaws. On the far left is parathyromatoses, which is by definition ectopic implantation of benign parathyroid tissue in the neck after displacement from prior surgery. These are thought to be just related to surgical procedure and not to malignancy, but they can be architecturally unusual because they have these multiple small nests kind of percolating through fat. But they shouldn't really have any vascular invasion, perineural invasion, etc. Um, all right. So that, wow, it's 9 o'clock. That's it. Good on timing. Do you guys have questions or comments?